morning, good afternoon, and good evening to our distinguished speakers, chairs, and audiences of the ACNS webinars. We are here today for the last webinar of the month of July 2021. The first speaker of today is our honored guest from Japan, Professor Masaki Komiyama. Professor Komiyama is the Director, Department of Neurointervention, Osaka City General Hospital, Osaka, Japan. Professor Komiyama reserves his subspecialty in cerebrovascular diseases, pediatric vascular diseases, hereditary hemorrhagic telangiectasias, head and neck vascular diseases, and neurovascular anatomy. He is a very well-known research scholar who was also a past editor-in-chief of the Journal of Neuroendovascular Therapy till last year. He is a member of the Japanese Society of Neuroendovascular Therapy, the Japan Neurosurgical Society, the Japan Congress of Neurological Surgeons, as well as many other important international organizations. Professor has a special interest of research in the disease hereditary hemorrhagic telangiectasia, also known as the Osler-Rand-Weber syndrome. He is a member of the Global Research and Medical Advisory Board for Cure HHT and also the HHT Society of Japan. We are extremely honored to have him today as a speaker at our webinars, and today he will be talking about his favorite topic, which is HHT. The second speaker for today is our honored guest and senior faculty from China, Professor Yu Bo. Professor Bo is the Deputy Director, Stroke Center, Shenjing Hospital of China Medical University. He is also the Deputy Director of Neurosurgery Department and Liaoning Medical Association. He is the Deputy Chairman of Liaoning Province Neurological Intensive Diseases and Intervention Committee. He is also a member of several organizations, namely the Chinese Medical Association Neurosurgery Intervention Committee, National Committee of the Neurointervention Committee of the Chinese Medical Doctor Association, and member of the Standing Committee of the Interventional Branch of the Liaoning Medical Association. We are extremely honored to have him today as a speaker at our webinars, and today we'll be talking about the progress in intervention treatment of intracranial aneurysms. The chair for the first session of today's webinar is an honored guest from China, Professor Xianli Elwei. Dr. Xianli is an associate professor of endovascular neurosurgery department at the Beijing Tsinghua Chenggang Hospital School of Clinical Medicine, Tsinghua University in Beijing. His research focuses on endovascular neurosurgery of intracranial aneurysms, cerebral AVMs, intracranial AVF, and spinal AVMs, and pediatric cerebrospinal AVMs. He is an editorial member of several journals, including Intervention Neuroradiology, Stroke and Vascular Neurology, Journal of Neuroradiology, and Neuroradiology Journal. He is also deputy editor of the Neuroscience Informatics. Dr. Xianli is a member of the World Federation of Interventional Therapeutic Neuroradiology. We are extremely honored to have him today to chair the session of Professor Komiyama. The chair for the second session of today is our honored guest and very senior faculty from Japan, Professor Shinichi Yoshimura. Professor Yoshimura is a professor and chairman, Department of Neurosurgery, Hyogo College of Medicine, Hyogo, Japan. Professor Yoshimura was the past president of the Japan Society of Neuroendovascular Therapy. He is a board member of the Japanese Society of Neuroendovascular Therapy, the Japanese Neurosurgical Congress, and the counselor of the Japanese Stroke Association. He was the past editor of the Journal of Neuroendovascular Therapy as well. He was the president of the Mount Fuji Congress as well as Japanese Neurosurgical Congress in the past. We are extremely thankful to him for lending his support for our webinars on more than one occasion. Today, he'll be chairing the session of Professor Yu Bo. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and audiences to this online platform of ACNS webinars. A very special welcome to our main mentor from China, Professor Shubin, who has been relentlessly supporting us throughout our journey. Welcome, Professor Shubin. And Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to the first chair, Professor Xianli Elwei.
Happy to see professors here. Tonight we have two presentations. The first is HHT topic from Professor Komiyama. The second is aneurysms, endovascular treatment of aneurysms from Professor Yu Bo, who is Chinese neurosurgeon. And after their presentation, we will have a discuss about the topics. Okay, thanks.
It's a great pleasure for me to join this wonderful webinar tonight. And I'd like to share my experience with a participant. I'm not sure how many doctors here has already seen the patient with HHT. HHT is a rare disease, it's so sad, but it's actually not a rare disease. It's an under-recognized disease. Let's start with my lecture. My hospital located in Osaka, western part of Japan, and actually living in Kyoto, nearby the Osaka. As you know, the Tokyo, the Olympic Games is going on. And my hospital here is around the Osaka Bay, we have the castle here, and nose to the castle, the 2 kilometers, we have the hospital here. Our hospital is just 30 years old, and the castle is over 400 years history. My topic today is 8 items. What is HHT? And the typical symptoms are nosebleed and telangiectasia, and diagnosis and genetics and the characteristics. And there are visceral AVMs, pulmonary, brain, the spinal, and also the short lectures on the hepatic AVM and GI tract AVM. Then finally, we start to talk a little bit about the screening and the recently published the second international guideline. What is HHT? It is well known over 150 years ago. This paper is known to the first description of HHT in 1864. And this paper described this disease, the Epistaxis, hemiparesis, and the family history. Next year, in the Lancet Journal, it's also this article described this disease, Epistaxis, and the family history. And this paper describes 5 generations in detail in the family history of the disease. Early in 20th century, this is Dr. Osler, he published the paper in John Hopkins Hospital Bulletins on this disease. He says it's treated the Epistaxis, mucocutaneous telangiectasia, and family history. And his pupils and Hereditary in the later 1909, he published this article, and he used the word HHT, hereditary hemorrhagic telangiectasia. Of course, this disease is also called Osler-Lender-Weber disease, but internationally we call it HHT because it's more common now. And his description, the hereditary, recurrent hemorrhage, and telangiectasia and anemia. Summarizing these pioneer works describing this disease, we can easily understand the disease characteristics. Epistaxis, mucocutaneous telangiectasia, family history or hereditary, recurrent hemorrhage and anemia. Let's start with a nosebleed, epistaxis. This patient, my patient, came to my OPD and had nosebleeds when he was waiting for me, and he pushed the plugs here. You can see the telangiectasia, cutaneous telangiectasia on the face. When you use the fibroscope to look into the nasal cavity without hemorrhage and during the hemorrhage, you can see the telangiectasia. There's various types of the regions. This punctated, isolated regions, this diffuse, and also solitary AVM we have. It's mostly those nosebleeds coming from the Kieselbacher area. I do not talk on the detail in the treatment of nosebleed, but there are so many treatments on this nosebleed. For example, the topical oral medications, laser surgery, and argon coagulations, and as a surgery, closure of the nasal nostrils or septal dermoplasty, and we use the embolization. Even with these treatments, it's very difficult to control the nosebleed. So people know, so the patient, HHT patient knows, regardless of treatment modality, nosebleed will continue. And we know the humidification is very important and most cheap and most effective treatment for nosebleed. How about telangiectasia? I'm going to show the several pictures, and if you find similar regions on the tongue or skin, you will easily find the telangiectasia HHT patient. This patient is a telangiectasia on the tongue. This is typical for this disease, because also this disease on the tongues. I think other than the HHT, no other dermatologic disease have a similar region on the tongue. You can see it here, and also on the lips. This 12 years girl has a small telangiectasia on the tongues. 2 years before this picture, she had no telangiectasia at the age of 10. This man has a telangiectasia on the tongue here, and also there's occasional bleeding from the face. There are many cutaneous regions on the face. This lady has many regions on not only the tongue, this lips, lower and upper lips, and the face, occasionally bleeding from the lips. This 26th man complained of bleeding from the eye. He went to the eye doctor. The eye doctor says nothing happens from the bleeding from the eye, but actually he had the bleeding from the eye, from the telangiectasia, the upper eyelid, the very common place for telangiectasia. This man has a telangiectasia on the earlobe, and also, of course, the telangiectasia also can be found on the hard palate. And this patient complained of bleeding from the throat region here. This patient has a similar region on the larynx here. And also, finger is also the common place for telangiectasia. You can see it here, here, here. With aging, these regions are increasing slowly. And another example of this old man had so many telangiectasia on the fingers. This is a typical place and no pain, occasional bleeding. You can see the here, 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 here. And the tongue and also finger is the two famous, most typical place for telangiectasia. This patient came to me and showed the hand to take the photographs and then start bleeding in front of me. So this is common. This region is not so common. It's so large, usually very small regions. This lady has on the chest wall. There are so many small telangiectasia here and here and here. From the mouth to anus, there's a possibility to have the similar region of telangiectasia. So the patient may have a GI bleeding, especially in the stomach. The stomach is the most common place of GI tract telangiectasia. And if the patient has a tremendous number of the regions, it's a parallel to the severity of the iron deficiency anemia. This is the telangiectatic regions on the stomach. Another example of the stomach, you can find many regions on the telangiectasia. In this gastroscopic view, there's no bleeding, but there's occasionally bleeding. And so it's a slowly progressive iron deficiency anemia found in the HHT patient. This is the schema of cutaneous and mucocutaneous telangiectasia. On the left side, this is normal. You can see the arterioles and venules in between the capillaries. Then some early stage of the telangiectasia, the enlargement of the artery in the veins with some change in the capillaries. Then finally, the arterioles are becoming large and venules are becoming large and there are direct shunt. We call this is a telangiectasia, but actually it is a AVM or AV shunt. This schema shows the nosebleed and telangiectasia in relation to the age. You can find the nosebleed when the patient at the age of, for example, 5 or 6. It's early presentation of the nosebleed, and they increase with the age. But this figure does not mean it's continuously worsening with the nosebleed. Sometimes patients stop nosebleed at the age of 50, for example. I don't know the reason, but some patient sometimes stops the nosebleed at the age of 60 or 61. But in contrary to the nosebleed, telangiectasia is constantly worsening. Its rate start in the middle age. For example, the 50 or 60, they start to find show the telangiectasia. And with the aging, they increasing the number of telangiectasia. It's not like nosebleed, it's constantly deteriorating. And next talk on the diagnosis and genetics and characters. This shows one family's histories. And this is a patient, the father has, mother has, and the father has the HHT mutation. This in this family is the endocrine mutation. This family pedigree shows autosomal dominant trait of this disease. What genes involved? Before the talk on the genes, I have to start with diagnostic criteria. This we call the Curaçao criteria. Curaçao means the name of a small island in the Caribbean island. There's 4 items: Epistaxis, spontaneous recurrent epistaxis; Telangiectasia, usually we found on the lip, tongue, and the fingertip; and the visceral regions, AVMs in the lung, liver, brain, and spinal cord. Telangiectasia in the GI tract also regarding the AVM. The family history within the first-degree relatives. If the patient has the 3 or 4 items, it's a definite. If the patient has 2 items, it's suspected. If the patient has only 1, it's less likely. And we call this Curaçao criteria is established a year of 2000. It's a specialist gathered on the small island of Curaçao Island near the Caribbean island, near the Colombia. It's maybe a beautiful island that they get together and establish this criteria. This is because the very kind of sightseeing island, but also this island is famous for hot regions of the HHT. HHT usually the similar incidents all over the world, but in this area, the hot spot for HHT. This Curaçao criteria is very useful among the adult. Positive predictive value for definite is 100%. Negative predictive value for unlikely also almost 100%. That means without genetic test, we can diagnose the HHT patient with this Curaçao criteria if the patient is above the age of 16. It's unfortunately this criteria is not useful for children. So sometimes we need to use a genetic test. How about the prevalence of HHT? It is said 1 patient among 5 or 8,000 is all over the world common. So we have 16 or 25,000 patients in Japan, but actually in Japan, less than 1,000 HHT patients registered. It means so many patients are underdiagnosed. It is the typical characters of this disease. The patient not come to the hospital or they do not want to be diagnosed with HHT. So, but we have so many patients around the world. How about the genetics of HHT? We know the 4 genes: endocrine, LK1, SMAD4, and BMP9s. But the HHT1 is caused by the endocrine mutation. The HHT2 is a ARC1 mutation, and the HHT1, HHT2 is all about 90% of the HHT patients are either HHT or HHT2. So SMAD4 mutation is caused JPHT, juvenile-polyposis, and the HHT overlap syndrome. This is, I think it's less than 1 or 2%. So we think we can reverse HHT1 or either HHT1 or HHT2 is responsible for this disease. Let's see what kind of mutations. Let's see the endocrines. There's so many variant type: silent mutation, insertion, duplication, missense mutation, nonsense mutation. The various kind of gene mutations found in endocrine, also ALK1. This means HHT gene mutations caused by the haploinsufficiency. It means the reduce the amount of the normal endocrine protein or ALK1. And what's the role of pathogenesis of HHT in the what's the role of endocrine ALK1? These 2 genes has played a role in the TGF-beta family pathway. TGF-beta family is very critical for controlling the angiogenesis and vessel repair. So lack of endocrine, normal endocrine or normal ALK1 result in the loss of function of these proteins. This means haploinsufficiency. This results in HHT presentation. Let me show our hospitals that we have already seen more than 300 HHT patients. This is the data from when we had 200 patients. About just more than the 50% of the patient HHT, and 33% of the patient HHT2. 9% unknown. Unknown means that the patient is diagnosed with HHT to have HHT by Curaçao criteria, but the gene examination failed to show some gene mutations. Let's see the characteristics of HHT1 and HHT2. This is our possible data. The HHT1 is younger than HHT2, and the pulmonary AVF, the brain AVFs are typical for HHT1. However, the hepatic AVF was typical for HHT2. Let's see it again. Genotype-phenotype correlation among the HHT. Early presentation in HHT, the nosebleed and mucocutaneous telangiectasia. Dermal head telangiectasia is common in HHT2. And GI bleeding and hepatic AVM is common to HHT2, whereas pulmonary and cerebral AVM is common in HHT. Of course, there is overlap between the HHT1 and HHT2, but typically we have the pulmonary or cerebral AVM among the HHT1 patients. Let's go into the talk on the pulmonary AVF and brain AVF and spinal AVF. When the patient develops some neurological manifestation, 2/3 of the patient was caused by not the brain disease or spinal disease, it's caused by pulmonary AVF. 1/3 of the patient was caused by neurological symptoms by brain region or spinal region. Why pulmonary AVF causes a brain neurological manifestation? This is caused by the paradoxical embolism. Right and left shunts cause the paradoxical embolism. This is caused by pulmonary AVF. It's caused TIA or cerebral ischemia or brain abscess. Let's talk on the pulmonary AVF. Among the HHT patients, almost half of the HHT patients have the pulmonary AVF. This pulmonary AVF can cause brain infarction, TIA, or brain abscess by paradoxical embolism or migraine. Migraine is a very typical symptoms of HHT. When we succeed the embolization of the pulmonary AVF, some patient dramatically says the migraine has gone. Also, pulmonary AVF can cause hemoptysis, hemothorax, dyspnea, chest pain, or cyanosis grabbing. This is a patient with the lower auto saturation due to pulmonary AVF. As you can see the grabbing and the pale color. Also, this patient has less than 90% of the saturation and the pale color and the grabbing you can find on the figures. And Angiographic, the pulmonary AVF, more than 80% of the simple type. This is quite similar to the PAVF AVF of the brain, feeder, varix, and drainer. And less than 20% of patients have a complex type. How to diagnose the pulmonary AVF? There are many ways to diagnose pulmonary AVF, but usually we use it to either contrast echocardiography or thoracic CT scanning. We prefer to use the thoracic CT, except for the children. For the diagnosis of pulmonary AVF, it's unnecessary to use a contrast. Let's start with a quiz. This is a simple chest X-ray. Can you find the pulmonary AVF somewhere in this 20-year female? The answer is here. Okay, you can find the pulmonary AVF here. Next, case 2. Could you find the lesions in this chest X-ray? Okay, here you can find the lesion at the A6 region. And okay, how could you find the region I think pulmonologists are very, they're very talented to read these films. Okay, you can see here the small regions and they're plugged with coils. Okay, this is a thoracic CT and the pulmonary AVF. Usually, and it's necessary to use a contrast, but if you want to use to see a separate artery or the veins or there is a small region near the heart, it's better to use a contrast. It is very common to have the multiple bilateral regions, and the pulmonary is very commonly located in the lower lobe. How to treat? The purpose of treatment of pulmonary AVF to improve the oxygenations, prevent hemorrhage, and prevent right and left shunts. How the indication of the pulmonary AVF treatment? It's formally it's said the feeder is larger than 3 millimeters or symptomatic, we should treat. But now, if the feeder is less than 3, we may treat the region if we can put the microcatheter to the feeders. And the treatment of the pulmonary AVF historically, the surgical resection in early days, but in the 1980s, we started the embolization of the regions. And as a brain AVF and AV shunts, we prefer to use platinum coils. Some radiologists prefer to use vascular plugs. And there's a big discussion where to embolize. And the radiologists prefer to embolize feeder only. There's a recurrence, high recurrence. I prefer to occlude the feeder and the varix. But with a majority of the patient, the doctors prefer to occlude the feeders only. So one example of the case is a 42 female, suddenly developed the left hemiparesis. You can see the regions here. Unfortunately, this patient already diagnosed AVF 10 years ago, but not treated. Every year, CT scan, oh, no change, the size no change. But if we find the pulmonary AVF, we have to treat to prevent the future embolism. The patient was brought to the local hospital. It's early change on the right frontal lobe, the occlusion of the MC and IC, and after the IVTPA and the tolerable regurgitation, finally regularized with the result of a TK2B result, and the patient completely recovered. And they treated in Tokyo, and then come to my hospital. I'm a neurointervention, but she came to us to treatment for the pulmonary AVF, and I put the coils, the feeders, and the varix, and completely occluded this disease. Another example, this 41 male has fever and appetite loss, and the MR shows the region on the left frontal lobe with definitely the abscess. And this is caused by the large pulmonary AVF here. This is the largest AVF I have treated. And okay, this is larger, I use the larger coils, and the feeders, I have to use 35 coils because of the so large feeders on this patient. And this is two cases. One on the left side, the varix is 7 centimeters, but goes left frontal abscess. On the right side, this is 7 millimeters regions. It's called occipital abscess. What the difference? What do you think? Which region is more likely to cause pulmonary AVF? I thought this large 7 centimeter region may have high chance to cause embolism for brain abscess. But this paper from South London, she examined, checked the various factors, feeder size, and multiplicity, and shunt percent oxygenation. So there's no primary determinant of the causative of the pulmonary AVF. So it means even the smaller AVF. This may cause similar possibility to the stroke or brain abscess. So I think that even the lesion is small, even the patient is a little bit higher age, we have to treat the pulmonary AVF to prevent stroke and brain abscess. Pulmonary AVF also cause hemoptysis and hemorrhagic in this case. And this 9-year-old female is the parenchymal hemorrhage, and she came to us with this large AV shunt here, and we the situation. This is a very interesting case. In the supine position, the 93% in the standing, with the road drops. We call it also the deoxia. And as usual, we put coils on this shunt. And interestingly, this patient, this girl, has a pulmonary arterial hypertension. It's about 25 millimeters. And usually, pulmonary arterial hypertension is caused by the ALK1 or BMPL2 mutation, but this patient has the endocrine mutation. Okay. Pulmonary arterial hypertension, of course, we are not the specialist for this disease, but if the patient has a pulmonary arterial hypertension left without treatment, the high mortality we know. So, and the HHT patient has involved in have ALK1 mutation, the endocrine mutation, or the possibility to have the pulmonary arterial hypertension. And there are two kinds of pulmonary hypertension HHT, precapillary pulmonary hypertension, post-capillary pulmonary hypertension. Precapillary you mean before the lung capillary, there's a cause. Pulmonary arterial hypertension caused by the precapillary resistance, higher resistance. And post-capillary pulmonary hypertension caused by usually hepatic AVM. There's a increased cardiac output. It is resulting in the post-capillary pulmonary AVF. And both these pulmonary hypertension is related, highly related to HHT2, especially HHT2 is related to the hepatic AVM. Alpha's AVM and HHT. The incidence of HHT is in general, or 10 or 20%. Its hemorrhage is between 0.41 or 2%. But the incidence is different in the HHT and HHT2. In HHT, 10% of the patients have the brain AVM. In HHT2, only 1%. If we regard the general population, it's 0.01% of the incidence. It means that HHT has a 1,000-fold, HHT2 the 100-fold increase of incidence to have the chance to the brain AVM. This is a report from the Toronto group. There are three kinds of the brain AVM. And you know the nidus AVMs, the most we are familiar. Usually this in HHT, the nidus regions are less than 3 centimeters. In the pediatric, we often have the pulmonary AVF. In HHT, we also found capillary vascular malformation. It's not there's no AV shunt, but if you have the angiogram, this is a stain without AV shunt. We call capillary vascular malformation. It's the entity is different from the nidus AVM. And almost half of the regions is a capillary vascular malformation. Also, less than half of the patients is a nidus AVM. AVF is very rare. It's less than 1% of the patients of the HHT have one AVF patient. And relation between the age and the brain AVF and the spinal AVF. And the spinal AVF is common in the pediatric population. And the brain AVF, higher AVF is also in the pediatric population. If the patient has nidus AVMs or small AVMs, it's adult populations. It's a completely different symptomatology among the pediatric population and adult populations. Brain AVM HHT has a typical characteristics. They have multiplicity and small size and superficial. These three areas is very typical for the AVM or HHT, nidus AVM in HHT. If the patient's multiple AVM for any reason, then the HHT the odds is 26-fold higher than without multiple AVM. Let's see the case. This is an enhanced brain T1 weighted image. You can find the enhanced region, the deep region, and the superficial regions. And we did the angiogram. We can find the small region that surrounds AV shunt. But on the surface, there's no AV shunt. It's only the stains. We call this a capillary vascular malformation. This is neither same small AVM. To find the capillary vascular malformation, we have to do the CAS angiography or T1 weighted contrast gadolinium enhancement study. There's no small enhanced region without feeder and drainers here and here and here. And I think the natural history of this capillary vascular malformation is not well known, but not likely to bleed. So if you don't want to diagnose capillary vascular malformation, it's usually no problem because this region does not bleed. Another example, the PAVF. This high school girl has a menstrual headache, and we found the parietal PAVF angiogram shows the PAVF with small angiogenesis here. We use a coil and glue and embolize, and this is complete occlusion. And the follow-up 4 months later is completely occluded. And AVM with nidus AVM in HHT, it's different from the non-HHT patient. As I told you, there's a multiple regions, small regions, superficial regions. And HHT and nidus AVM has a bleeding rate of 1.3% annually. But non-HHT, sporadic AVM has nearly 2-3% of annual rate of bleeding. So HHT regions are less likely to bleed. So the regions commonly conservatively managed. Some patients underwent the stereotactic radiosurgery. This is one example, 80 years old male, and in center discovered nidus AVM during the screening. I found this, and I sent this patient to the gamma knife, and 6 years follow-up, there's complete occlusion of the AVM. Spinal AVM is not so many spinal AVF in HHT was reported. And all of them were perimedullary type, and most of them start to bleed and show the paraplegia. I'm going to show my case. This spinal AVM bleeding here, and start announcing the paraplegia in this 6-year-old boy. And angiogram shows a small, the feeder left TH8, a small AVM here, but we have another feeder in the downward. Another feeder left L2 angiogram shows posterior feeders and the AV shunt here. So bringing the magic caster to the regions and occluded with the coils and near the occlusions. But the small anterior spinal artery, the feed shunt here, we are just closely observing this patient. This is a follow-up. No, this is the final angiogram. Hepatic AVMs. The hepatic AVM may show the 3 types of the symptoms: high output failure, portal hypertension, and biliary disease. Of course, we are not the hepatologists, but if we treat the HHT patient, we have to know that a little bit about hepatic AVM. If you this enhanced CT shows a large pulmonary artery and the hepatic artery and hepatic vein. There are 3 types of the shunt in the hepatic AVM: arteriovenous shunt, arterioportal shunt, and portovenous shunt. 3 types of shunt is a possibility. You can use abdominal ultrasound to find the AV shunt in the liver. But hepatic artery embolization is not contraindicated because of the ischemia causes serious fatal complications. It's well known. It don't treat embolization for hepatic AVM. This is the symmetrical T1 high region. This is caused by manganese accumulation. This is we scan the brain, but we can find the region in the hepatic. This is a portal venous shunt. Due to the portal venous shunt, we found this high manganese collections. Manganese is cleared from the rear. Almost all manganese are cleared from the liver. If you have the portal venous shunt, so the accumulation of the manganese on the basal ganglia, it's called sometimes the Parkinsonism. The GI tract bleeding, and we have often the gastric AVM and gastric telangiectasia, but it's a frequent nosebleed and the GI bleeding. It's caused iron deficiency anemia. But HHT, in HHT, massive GI bleeding is quite rare. And HHT-juvenile-polyposis overlap syndrome is caused by the SMART4 mutations. It's famous for these polyps. These polyps are high tendency to be malignant, so close follow-up is required. Screening for the HHT patient, the brain AVM, we use plain or gadolinium to enhance. Pulmonary AVM, either contrast echo or non-enhanced CT. The hepatic AVM with echo or dynamic sheet or MR. Spinal AVM, which is usually not the indication for screening. GI tract AVM is not the indication for screening. But if you find severe anemia, just thinking of the nosebleed, it is quite highly likely we use a fibroscope for GI tract. And gene analysis, commonly you use GI gene analysis. So at least when we have the patient, we do the brain scan, pulmonary scan, and gene analysis. This is a protocol for my hospital. After the interview and the close inspection of telangiectasia, we do the contrast enhanced in the brain, also brain scan. For the chest and the abdomen, we use a dynamic enhanced scan. And we check the pulmonary AVF, liver AVM, and spinal AVM. Of course, these spinal scan, we miss the small regions, but it's a screening. It's okay. We use this spinal screening. And we commonly use the gene analysis for 3 genes. Finally, I just spent a few minutes on the international guideline. This guideline initially published 10 years ago, and after the 10 years, the second guideline that published last year, I was luckily joined this guideline group. And all these people gathered 2 years ago to Toronto to discuss how to make these guidelines. And you can find these websites and in detail, the Epistaxis, GI bleeding, anemia, or so and so. I was joined the pediatric care group. Yes, and if you click the pediatric group, you can find the recommendation here. I'm just only show the pediatric recommendation. For example, the expert panel advice a diagnostic genetic test to be offered for the children of the patient of HHT. So like this way, for the pediatric patient, the pediatric patient, we do the genetic test and the screening for AVM and the screening for brain AVM is recommended. You can see directly type the HHT guideline, you can reach these regions. These are topics my talk today. And the conclusion. HHT is not a rare disease, but underdiagnosed one. HHT presents vascular dysplasia in many organs. The Curaçao criteria is very useful for adults. Pulmonary regions and brain regions are amenable to treatment. Thus, screening for the HHT is very essential. above all, high index of suspicion of HHT is necessary. Thank you for your attention.
Thanks, Komiyama, for your valuable presentation. Yeah. HHT is as you have said, not a rare disease. HHT is an autosomal dominant disease.
Yes.
It is usually called Osler-Weber-Randall syndrome. It has been first reported from 19th century. It is usually associated endoglin and ALK1 genetic mutation. Yes, according to the genetic mutation, HHT classified into two types, type 1 and type 2. Type 1 usually associated pulmonary AVM. HHT more associated with hepatic AVM, hepatic and gastrointestinal AVM. There's no evidence. There's no evidence for brain AVM associated with HHT have a high hemorrhagic rate compared to sporadic AVM. So unruptured AVM, brain AVM in HHT is more prone to observation, and their treatment is the same as sporadic brain AVM.
May I ask Professor Komiyama that if you find an AVM, is there any other signs than telangiectasia that we can look for in clinical examination?
Okay, as for the HHT patient, it's not so difficult. If you ask your parent has a nosebleed, your grandfather or grandmother has a nosebleed, usually they say yes, if it's a hereditary HHT. And you can see just the tongue, just open the mouth and I'd like to see your tongue. This is a very convincing finding to the patient at HHT, except for the patient at the pediatric. Otherwise, if the patient is adult, it's okay.
Thank you very much. My co-host, yes.
Genetic examination is necessary in all cases of HHT.
I don't think it's necessary, but if the patient the signs of hereditary, it's better to use a genetic test. We can confirm it's a genetic and hereditary.
In delivery.
Pardon me?
In delivery cases or suspected HHT cases.
Oh, if you suspect the HHT, you first see the history and examine the telangiectasia, and we check the blood sample for genetic test. But genetic test, we have about 10% negative result, even the patient with HHT. So we have to be cautious for the result of the genetic test. Even the patient with HHT, 10% of the patients are negative genetic mutation.
That is very interesting. Any comments from Professor Shubin?
Thank you for Professor Komiyama, and this is a very informative presentation, and I learned a lot. Actually, I did some animal model for the HHT about 20 years ago in San Francisco, in UCSF. I used adenovirus for the VGF gene to inject into the endocrine knockout mouse, so induced the angiogenesis and mimic this HHT model.
Yeah,
it's quite interesting, but actually in clinic work, I never treated this kind of disease.
I will be a bit surprised for me, because UCSF is very famous for experiment for AVM, especially they are familiar to the experiment. I skipped the experiment of the Norwich information on this lecture, but many papers coming from UCSF. I know.
Yeah.
Thank
you.
My co-host, Dr. Yubun Singh, any comments from your side?
Thanks, Raja. Thanks, Professor. I only have one question, Professor. In which cases that you will suspect HHT, and which patient that you will do extracranial vascular imaging, especially those who don't see the external sign or cutaneous sign, for example, the nosebleed or tongue sign. What are the criteria to do extracranial vascular study? Thank you, Professor.
Okay, as I told in the lectures, more than 90% has nosebleed, epistaxis. And if the patients are old enough, you can find the telangiectasia of the tongue or finger. And if you suspect this is an HHT patient, you can ask the family history. This is a convincing fact. Then, if you really suspect the patient HHT, you can screen the brain and at least lung. And you can, of course, consult the genetic test. But if you have difficulty to consult the genetic test, you can scan the brain and lung. It's a minimum requirement for screening.
Thank you very much. With that, we can end our first session. Thank you very much, Professor Komiyama. It was an excellent lecture, and totally we did not know so many things about HHT, and we learned a lot from you. And I would like to invite our second chair, Professor Shinichi Yoshimura.
Hi,
Professor
good evening.
Yoshimura.
Yes, good evening, everybody. Dr. Yoshimura speaking, and I'd like to invite next speaker, Professor Yubo. He's going to talk about advances in intervention treatment of AVMs and aneurysms. Please start your lecture, Professor Bo.
I will begin now. Thank you very much. Thank you, Kono Yama, and Dr. Shi, and experts. I will begin. Dear experts, this is Dr. Yubo, a neurosurgeon from Sengjing Hospital of China Medical University. Today, I will introduce to you the new progress of interventional treatment of complex aneurysm. The time-honored Sengjing Hospital was founded in 1883, which has 4 branches: Nanhu, Huaxiang, Shenbei, and Benxi, with 6,570 hospital beds. This is our stroke center team. This video records the rupture of an aneurysm. The rupture of an aneurysm is critically dangerous. The following 5 types of aneurysms will be introduced today, include young patient aneurysm, tortuous path vascular aneurysm, multiple aneurysms, microaneurysms, fusiform aneurysm. And the following 4 methods of complex aneurysm embolization will be described, including spring coil basket technology, multi-microcatheter technology, stent assist embolization technology, blood flow guiding device technology, named PAD. The first case, a boy was 6 months old and developed epilepsy, diagnosis with intracranial diabetic aneurysm. CTA show enlarged middle cerebral artery and a large dynamic aneurysm. Due to the age of so young boy, it was really hard to puncture the femoral artery. Plus, there were no anterior seat and a thinner contrast catheter suitable for young children. We use a trocar and a microcatheter for this operation. Using a microcatheter to make road map, we could find a large dynamic aneurysm. We can tell from the video the spring coil rotates at high speed under the impact of blood flow. We can see. Blood flow was turbulent. In order to prevent overperfusion injury, we use a fractional embolization as planned, with 50% of the first embolization. The child was in good state the third day after surgery. Only 50% of the blood flow was blocked for the first time. 10 months later, the remaining half of blood flow was embolized. The child recovered well after the operation and did not have epilepsy. After 6-year follow-up, the children's speech and physical activities are in perfect condition. Also, there are no recurrence of epilepsy 6 years.
研究啥性部问题现在呀？
妈妈，你有没？Second, our cultures has aneurysm. The patient has hemorrhage of subarachnoid. CTA show a tiny aneurysm. Aortic arc angiography shows that the subclavian artery and the beginning of the vertebral artery were very tortuous. Walking catheter were difficult to go through. So we changed to radial artery puncture. As you can see, the press is still tortuous. Application of coaxial technology to make working catheter reach pica aneurysm. This is the mid catheter and the macrocatheter. The macrocatheter reach the aneurysm. It's very dangerous, I think. The aneurysm is tiny. We use a tiny prime coil to embolize the aneurysm. Working position DSA. The embolization of aneurysm was completed and the pica artery was protected. Stent-assisted embolization technique. Stent can protect the aneurysm-bearing artery and reduce recurrence, dense embolism at the neck of the aneurysm. Endocellular cell formation on the stent surface and improve blood flow. As you can see, this is the key diagram of stent-assisted embolization of aneurysm. The purpose of the application of the stent is to cover the neck of the aneurysm. And finally, the endocellular cells cover the stent to achieve anatomical repair, like this. This is a small aneurysm with a tortuous artery. We prepare to plant a stent from A2 to A1 artery and push the microcatheter, use coil. We complete the dense embolization of the aneurysm. Another PACA aneurysm use stent-assisted embolization technique case. The right vertebral artery branched PACA and turned 180 degrees, made it difficult to enter the stent microcatheter. This is aneurysm and PACA. So we choose to place the microcatheter to embolize the aneurysm from right vertebral artery and place the second catheter from the left vertebral artery. Climb hills technique. Climb the hill. The red arrow indicates the stent catheter, with the yellow one embolization catheter. As shown in the picture, this is dense embolization of PACA aneurysms with the aid of stents. This is the image after embolization. The PACA protect well. This case of aneurysm of internal cardiac artery. It is so big. We plan to place a stent in the internal carotid artery and embolize the aneurysm with the aid of stent with coil. This is the image of our dense embolism. Sometimes we encounter some multiple aneurysm. This patient have two aneurysms at the same time. We use a double microcatheter technique with one stent and two microcatheter to embolize the aneurysm tightly. We implant microcatheter in the first aneurysm. Then we implant another microcatheter in the second one. We put a stent in internal carotid artery to protect both two aneurysm necks. the successful embolization of the aneurysm with coils. Once well, we plant 2 stents in a Y shape to protect aneurysm neck. In this type of bifurcation aneurysm, we use Y-shaped stent placement, such as this. One put in ICA, the other put Pecom artery to protect the neck. (3D) imaging after embolization. The prognosis is satisfactory. Ice cream technique for embolization of aneurysm. This aneurysm has 3 and 2 branches from the aneurysm. Traditional stent placement is difficult to protect the 3 branches at the same time. So we use ice cream technique that release the stent inside the aneurysm like this and put microcatheter here. The aneurysm is embolized with spring coil under the protection of the stent, and both M1 and 3 and 2 are protected. This case of a large aneurysm at the tip of the vascular artery, both P1 start from the aneurysm and are extremely curved, making it difficult to place a stent in a Y shape. Therefore, ice cream technology of placing a stent in the aneurysm is used. The surgical process. The big aneurysm. We open the stent in the aneurysm and embolize the aneurysm with assistance of the stent. With the help of the stent, the aneurysm embolization was satisfactory and the P1 arteries were well protected. Like this. With the continued improvement of the stents design, the adhesion of the stent is getting better and better. This is a half-year follow-up of a case of EP2 stents. The result is satisfactory. We devise PAD. PAD can interfere with the flow of blood in the aneurysm, causing the blood in the aneurysm to become blocked and signaling, leading to thrombosis in aneurysm and further promoting its complete occlusion. PAD form a scaffold for vascular endothelium to climb and grow. After the implant is covered by the vascular endothelium, it can completely isolate the aneurysm from the artery. This case is internal aneurysm treated by PAD. We can see the high flow contrast agent filling the entire aneurysm before operation. After placing the PAD, the laminar flow in the stent is clear thin, while the blood flow in the aneurysm cavity outside the stent is significantly slowed down. The second case of fusiform aneurysm was compared with PAD 1 week before and after operation. We can find that the fusiform expansion of this vertebral artery was significantly improved after 1 week. While the branches of the pica artery were well protected. Only 1 week. This is an enraptured posterior community artery aneurysm, an anterior choroidal artery aneurysm. Two important arterial branches start from the aneurysm and need to be protected. After placing a PAD for 6 months, the aneurysm can be clear thin. The two important branches are well protected, reflecting the excellent performance of PAD. Next, I'm going to introduce two complications. When complications happen, it's very dangerous. This is a case of anterior communicating artery aneurysm. We placed a stent catheter. Embolization of the tiny aneurysm. We encounter intraoperative bleeding here and continue to embolize the aneurysm carefully and stop the bleeding luckily. The post-operative Diagnostic CT show only a small amount of hemorrhage. This case is aneurysm of P2 artery. We densely analyzed the aneurysms with the aid of stent. Two years later, the patient recurred subarachnoid hemorrhage. we can see recurrence of aneurysm here, so big. This time, an isolated technique was used to accomplish the embolization of the aneurysm. This was another case. 1 year after the operation, the patient suffered recurrence of aneurysm. So we analyzed the neck of the aneurysm for a second time, which had a good result. To sum up, the continuous introduction of new technical materials have enabled more options for interventional treatment of aneurysm and expanding indication. The application of stent allows most complex aneurysms to be treated. Individually, select stents and technique according to the characteristic of aneurysms and blood vessel. Focus on complications is very important. Thank you for your time. Thank you very much.
Thank you very much.
All right, thank you for your wonderful lecture about your various techniques to treat cerebral aneurysm by endovascular therapy. My first question is, you presented many techniques, but what are the important factors to avoid complications in endovascular therapy for cerebral aneurysm?
It's very important in the operation. We carefully action is very important, and we choose microcatheter and a stent and a coil suitable for the patient is very important, I think.
Next question is how to control platelet aggregation before treatment of stent-assisted coiling or flow diverter treatment. Do you administer aspirin and plus another agent medication before stent-assisted coiling?
Before operation, we use stents. We use aspirin,
Only?
and aspirin.
Aspirin and the Pravix for
Yeah.
3 to 4 days. Then
Okay.
after that,
in case of Asian, we are Asian, right?
yes.
In case of Asian, 20 to 30% of patients are resistant to Pravix, right? Clopidogrel, right? So sometimes patient may form thrombus in the stent or around there, right? So we usually measure the platelet function before treatment by verifying now or other machines. Do you usually use some machines to measure platelet function before treatment?
Yes, it's routinely measured.
Mm-hmm.
Just as you mentioned that we are Asians, and normally some patients are very sensitive to aspirin.
Right, right.
It's not like Western people. They usually use 375 milligram, but normally we only use 100 milligram. and we also measure the thrombus before.
Verify now.
Yeah,
Yes.
yes.
Okay,
Yeah.
we understood. Dr. Komiyama, do you have any comment about Professor Ru's talk?
We can invite
Okay.
Dr. Komiyama.
Thank you. Nice lectures. I'd like to ask one question on the pediatric case you presented rather when you start the lecture. One pediatric patient with MCA aneurysm case you have. It's a pire AVF or aneurysm. It looks like pire AVF. That's left MCA bifurcations, not the aneurysm, or it's aneurysm you sacrificed with coiling, staged coiling, and sacrificing the left MCA. It's an aneurysm case or a pire AVF.
Yes, I agree with you, Professor Kamiyama. It's I think it's AVF.
Okay.
Yeah. Because you see the expansion of the MCA, the feeder is much enlarged.
Yeah.
It should be an AVF, but it's a blood flow related aneurysm. Also, you can call it aneurysm.
Yeah, I think you staged 2 stages for occluding the left MCA, but I think one stage occlusion is a safe procedure, I believe. If I have this case, I will occlude one time.
Yes, if I treat, I also will occlude it to the 1 stage. Sometimes use balloon assist.
Okay, thank you.
Thank you very
They are
much.
very big hospital, Shenjing Hospital. You see, they have more than 6,000 beds. And actually, Professor Yubo is very experienced. Now he mainly focuses on the interventional treatment. Annually, they have around 1,000 case for interventional treatment. Yeah, it's a huge number. Yeah.
Thank you, Dr. Xu. Sorry, thank you very much.
Thank you
You're
very
welcome.
much. I think with that we can wind. Liu, would you like to ask anything?
No, I don't have any question. Thanks.
Thank you very much. So we'll wind this up officially now. We can hear the concluding remarks from Professor Yoshimura.
Thanks, Professor Yu. Presented us many challenging cases of aneurysms. Thank you. I have no question.
Thank you, Professor Yoshimura.
Thank you, Dr. Li.
Professor Yoshimura.
Thank you both, Professor Kamiyama and Professor Yubo. So tonight we also broadcast your presentation in the WeChat channel. Actually, tonight, although there's some Olympic Games, but we have still 2,000 audience in the WeChat channel. So watch your presentation. Thank you again.
That is a huge number.
Yes, it's 1,974 now, almost 2,000. Yeah,
that's very great. So I'll wind this up officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Professor Komiyama and Professor Yubo, as well as both the chairs, Professor Stanley LV and Professor Shinichi Yoshimura. A big thanks to Professor Shubin, who is our main mentor, for arranging the WeChat channel for today. And also thank you, Liu, for coming here and being my co-host for today. Until we all meet on the 4th of August, it is bye-bye from all of us here. Thank you very much for joining.